everybody, and welcome to our webinar today. We are talking today about long COVID and care access, and we appreciate you being here. It looks like we have a few people still getting connected into audio, and we're a bit of a smaller group today, but we do have a packed presentation to share. So without further ado, we'd like to just dive right in. Thank you all for joining us so promptly. So today, as I said, we're talking about long COVID and care access, and specifically how technology can support that access with a special lens looking at the long-term care settings. So today we are joined by Laura Sklaroff. I apologize, I did not check that is the correct pronunciation. But Laura is a member of our team here at Comagine Health. She holds a master's degree in applied psychology and evaluation and will complete her doctorate of education focusing on organizational leadership and learning in 2023. Her dissertation research examines the role of technology to support care access for people with long COVID and safety net care settings. Ms. Sklaroff has more than 15 years of experience conducting research and evaluation work focused on ambulatory sensitive chronic conditions, vaccines and infection prevention, health technology, and quality improvement strategies. Prior to joining Comagine Health in 2022, where she oversees evaluation efforts focused on quality improvement, Ms. Sklaroff was a researcher and evaluator for the Los Angeles County Department of Health Services, the second largest safety net health system in the United States. Ms. Sklaroff has taught graduate level program evaluation theory and methodology at California State University, Northridge, for over a decade and is an active member of the American Evaluation Association. And I am very pleased to have Laura join us today to share her expertise and a lot of research that she's put together around this topic. So thank you, Laura. Welcome.
Hey, thanks everyone. Thank you. So like it was mentioned, I'm going to be talking to you about long COVID and care access. And basically, I'm an applied researcher and applied evaluator. So I like to think about what we can do to take the research and apply it to a real world situation. And then as Adrian mentioned, I am also an academic. So if I start going into academic language or going into professor mode, jump in there and just tell me to pump the brakes. And if you have a question, please feel free to jump in. Especially because we have a smaller group, this is a really great opportunity to have a discussion. So I'm really excited to just share what I've learned about long COVID, the work that I've done, and talk about how you can apply it in your practice and in your day-to-day. Let's see. So just to kind of recap what the learning objectives for today are, we're going to talk about what long COVID is, the prevalence, the symptoms, and the sequelae. We're going to discuss how you can use information about long COVID to support residents in long-term and post-acute care settings. And then we're going to discuss the importance of trauma-informed care approaches to support folks who have long COVID. And just to share a little bit about the language that I'm planning on using for this discussion, I like to use person-first language when talking about healthcare topics, about diseases and conditions. So I will refer to folks with long COVID as people with long COVID. And some of the quotes that I have from different people who have the condition, they may refer to themselves as long haulers. That's a phrase that's been adopted by many people who have long COVID, particularly those who contracted it early in the pandemic. I also want to recommend, if you are going to be talking about people who have long COVID, avoiding the term survivors. There's kind of a lot of backlash around that term because, as you can see from this quote, many people are still suffering. They don't feel like they've survived. So there's kind of some pushback against using that term. And Adrian, I'm going to count on you to keep an eye on the chat because I'm looking at the screen.
Absolutely. Right. No problem at all.
Okay, great. So first off, just to talk about what long COVID is. So in the literature, the official name, post-acute sequelae of SARS-CoV-2 infection, or referred to as PASC in some instances, otherwise known as long COVID. This is a condition that we're still learning a lot about it. Right now, the kind of common definition is that it is a condition that occurs and lasts for more than 4 weeks post an initial COVID-19 infection. It has been documented as impacting up to 10 different body systems and has over 200 documented symptoms and sequelae. So this is a very big bundle of different symptoms that we're looking at. I've included the most common on screen. Fatigue and exhaustion or post-exertional malaise are really some of the highest. Close to around 98% of people with long COVID will experience those. And by post-exertional malaise or PEM, I'm talking about people who are, in their 30s and will describe taking their dog for a walk around the block and then needing to come back and take a nap for 2 hours to get back to their baseline. Other symptoms that have been documented around long COVID include brain fog or cognitive dysfunction, chest pressure, breathing difficulty, visual or audio disturbances, so hearing ringing in your ear, seeing floaters, having light sensitivity, neuropathy, so having pins and needles in your hands and in your extremities, tremors, joint pain, post-orthostatic tachycardia syndrome, so basically standing up and having your blood pressure do one of these, so you get dizzy on standing or sitting or changing your body's orientation, changes to menstrual cycles for folks who menstruate, chronic diarrhea, fever, chronic cough, and then depression and anxiety. And for that one, it's a bit of a chicken and the egg situation. So some people believe that depression and anxiety occur directly because of the long COVID or PASC. Other people believe that it's sort of a response to dealing with the symptoms and the sequelae of living with long COVID, but it is fairly common for folks who have it. If you are doing charting or looking at medical records for people who have long COVID, there is an ICD-10 code for it. It's just post-COVID-19 condition unspecified, and I've included it here on screen. So if you do charting, you may see that or may be able to document it. This code has only been in use for about less than 2 years now. So it's not widely known, it's not widely used, but it is starting to pick up in use. However, it doesn't really get into any of the different symptoms that folks experience. It just sort of documents an overall presence of long COVID. So what I have on screen now are how long COVID symptoms present and impact different organs with different types of pathology. These images are from a really awesome article, and this is where I have my nerd academic hat on. And so it's kind of the definitive meta-analysis, meaning that they reviewed all of the existing literature to date as of early 2023 around long COVID and compiled it all into one analysis. And so that's something that I'll share with Adrian to send out to everybody after this webinar. And but as you can see on screen, there are lots of different systems that are impacted by long COVID, and the pathology is pretty varying. So impacts to the heart, impacts to lungs, impact to the immune system, impact to the gastrointestinal tract, impact to blood vessels, kidney, spleen, and liver, impact the reproductive system. So hopefully everybody can hear me okay. I just got a internet is unstable pop-up, but we're good. Okay, great. So it's one of those things where we are seeing a lot of impact on different parts of the body. As I said, over 200 documented symptoms related to long COVID. So thinking about who has long COVID. So as of right now, the estimate is that 65 million people or more worldwide and more than 10 million people in the United States have long COVID. Incident rates kind of vary, the estimates kind of vary. The most commonly accepted are that 10 to 30% of people who have COVID-19 and are not hospitalized will develop long COVID. 50 to 70% of people who have hospitalization resulting from COVID-19 will develop long COVID, and 10 to 12% of people who are vaccinated and contract COVID-19 will still develop long COVID. It's associated with all different ages and acute phases of disease severity. So there is a very widely spread misconception that children cannot get long COVID. They absolutely can. There are, basically we're seeing the majority of patients who have long COVID as being between 36 and 50 years old who are not hospitalized. This is probably due to the fact that these are the people who are being tested, and these are folks who were exposed to COVID either through work, through family members earlier in the pandemic. So there is kind of a guesstimate that happens because at the beginning of the pandemic, people weren't being tested. We didn't have broadly available testing for COVID-19. And then at the later end or little later part of the pandemic, there was a broad availability of at-home rapid tests. So people weren't documenting their COVID-19 with their healthcare providers. And many of the studies and the research that goes into coming up with these estimates has a requirement that people have a documented positive COVID-19 test in order to count them. So it is likely that these are undercounts of who has the disease. The kind of general rule of thumb is that 10% of people who do not die from COVID-19 will develop long COVID symptoms. So that is symptoms that last for more than 4 weeks beyond their initial infection. I've spoken with people, and there are cohorts of people who contracted COVID-19 very early in 2020. They're still suffering from long COVID, bedbound. So it's a chronic condition. So just be aware that it's about 10% of people are going to be experiencing long COVID. As you get additional COVID infections, you do increase your chances of getting long COVID. And there has been some initial research, although it's kind of still in the early phases, that people who start Paxlovid, when they contract COVID-19, have a lower incident rate of having long COVID develop, although that study is still kind of being developed at this point, but it is just sort of something to be aware of, that Paxlovid has been shown to be a little preventative for the condition. So like Adrienne mentioned, I am doing my dissertation, hopefully finishing it up fairly soon, on long COVID and technology. So I'm going to share some of the original research that I did as part of my dissertation, and then talk about how that plus sort of what the general sense of the literature says, and how that can be applied to helping the folks and the residents who you're taking care of. So going into my own research, I wanted to look at what barriers folks with long COVID experienced and how they were impacting their healthcare access, how technology could be leveraged to improve that access, and then what else was needed to support the technology utilization for improved care access. So in order to answer these questions, putting my academic hat on, I did a convenient sample and snowball recruitment process, which essentially means I took to the internet and went to a number of the groups that have organically developed on Facebook, on Twitter, on Instagram of people who have long COVID, and spoke with them and invited them to participate in a survey and invited them to participate in interviews. So in general, I surveyed 186 people. I also conducted 28 individual and group Zoom interviews, in addition to people with long COVID who I allowed to self-identify, so I didn't need proof of a positive COVID-19 test. I spoke with different healthcare providers. I spoke with healthcare system executives. I spoke with medical informaticists, and I also spoke with the partners, the family members of people who have long COVID. The types of things that we talked about included the symptomology and the length of their long COVID, where they were learning about COVID-19 and long COVID, the impact that the condition had on their household, their work, their school, their quality of life, how they use technology, what they wish their doctors and care providers knew. And then I got some information about their insurance statuses and if they had a primary care provider. So really trying to get a good sense of who was out there with long COVID and what was going on. So in terms of the people with long COVID who participated in the survey that I did, more than half of them reported between 10 and 20 new symptoms that they attribute to long COVID. A third of them experienced symptoms for between 2 and 3 months at the time they completed the survey, and a third experienced symptoms for more than 1 year at the time they completed the survey. About 86% had an identified primary care provider, a little more than half had private insurance, and a little more than 20% had publicly provided insurance, including Medicare and Medi-Cal patients. Nice distribution of different income brackets. So 30% had households that made under $50,000, 20% or around 20 to 24%, 50 to 100,000, 100,000 to 200,000. And about 15% of people declined to report. So it's kind of a nice spread of folks with different insurance statuses, different lengths of having long COVID. And most of these people, because they were engaged in the long COVID community, were pretty active in their health. And so they did have an identified primary care provider. And this is what I found in terms of symptoms. So this is coming from the close to 200 people that I surveyed. As you can see, about 94% experienced tiredness and fatigue, about 87% experienced brain fog, and we had post-exertional malaise, shortness of breath, difficulty breathing, lightheadedness was high on the list, difficulty sleeping, which is very common in the literature. Symptoms that get worse later in the day, so sunsetting is a very common occurrence for people with long COVID where they get worse towards the end of the day. So doing things earlier in the morning is a lot easier. Different changes in moods, having pins and needle feeling in their extremities, sensitivity to light or trouble looking at screens, new sensitivities to food, rashes that develop, changes in menstrual cycles, and fever were all reported from this population. So in order to look at the survey, which was a mixed method survey, so people were able to answer some questions with free text as well as the interview data. I did 2 stages of analysis. So I'm going to kind of go through this a little quickly. And if you're curious and you want to talk research methodology, I'm happy to do that. So first, doing word clouds to sort of see what themes popped from different questions. So this on screen is what people with long COVID wish their doctors knew. So symptoms, time, real, it's real. So gaslighting was a commonly described concept. This is looking at the impact of long COVID on a household. So energy was a big theme. Needing help or not being able to provide help was a large thing. Impact on kids, on spouses came up a lot. This is the impact on daily life. So needing rest, not being able to exercise, not being able to work. A lot of people said, I used to be able to do X, Y, and Z, and now I can't. So I took those different analyses and used those to come up with an in vivo coding schema. So this is, again, that nerd hat, academic hat coming on. But basically did some coding of what people had to say to look at basically the symptoms they were discussing, their care access and care delivery comments, and then how they were feeling, seeing if there was sort of a traumatic element to that or not, or a trauma element to that, looking to see if it impacted them at the individual level or if it impacted their friends or family, and then ultimately coming up with some different themes. So impacts, or looking at, looking at uses of technology or reliance on friends and family, desires around care delivery, which were really based in condition acknowledgement and having team-based care, and then understanding the impact of long COVID on the individual, their household, and their work and school and community life. So the findings from the research work that I did really fall into three different buckets. So understanding the variables that influence care access and quality of life, understanding what people with long COVID wish their care team members knew, and then looking to see how technology can support people with long COVID. So this is sort of the spectrum of the different variables that impact care access and quality of life. So we have our long COVID symptoms, and this is by no means the comprehensive list, but these are kind of the biggies, and the related emotions. And it was really stressed by the people with long COVID who I spoke with and shared this with to kind of vet it, that we differentiate those two. The idea being that, as I had mentioned earlier, depression, grief, fear, frustration are not symptoms of long COVID. They're resulting feelings and emotions that happen because of living with long COVID. Really prominently discussed in the interviews that I did with partners of people who have long COVID and people's survey responses was accepting and understanding this change to self and status. So having rapid shifts in ability level, even on a day-to-day, within a daily basis. So earlier in the day, being able to get up, get out of bed, go for a walk. By the afternoon, you're bedridden, essentially. Same for having altered ability for mental exertion and altered ability for physical exertion. So people who are able to do complex cognitive work earlier on are no longer able to do it. One gentleman I spoke with was a computer programmer, and he said that basically since contracting long COVID 2 years ago, he hasn't looked at a computer. He just isn't able to mentally get there. Physical exertion, people who were athletes, people who ran marathons, people who went for hikes, rode bikes regularly, were bedridden, were becoming exhausted by doing very simple day-to-day activities. And these changed and rapid shifts in ability level and mental exertion levels really altered levels of independence for people rather quickly. So not being able to drive yourself anymore and being reliant on others, not being able to prepare a meal for yourself. And so the actual change in that ability level and level of independence was kind of a shock for folks, as well as some of the grief surrounding that and the reliance on others to care for them. Other folks talked about altered tolerance to external stimulation, particularly people who had younger children. But light sensitivity was a big one, noise sensitivity was a big one. And then the changes in how folks engaged with friends and family members. And so this was part of the reliance on others for help, as well as frustration with people who are no longer masking or who no longer would engage in COVID-19 safety protocols, because a big concern for a number of people with long COVID is becoming reinfected with COVID-19 and having their condition worsen. There were a number of socioeconomic barriers that people discussed. If you know social determinants of health, these are going to be pretty familiar to you. So digital divide and lack of technology-related resources, missing work, the expense of healthcare, and just the overall expense, particularly because long COVID is not recognized as a condition that you can file for like unemployment for or disability for. And then the reliance on public systems of transportation or reliance on others for transportation for getting to doctor's appointments. Then sort of looking at the healthcare system levels at the provider and facility level, just sort of the lack of long COVID knowledge and lack of trauma-informed care knowledge, the distance to get to care venues if you were required to go in for face-to-face care, and then that fear of additional COVID-19 reinfection. And then just sort of at an organizational level, people described kind of the intersecting systematic and institutionalized types of discrimination, particularly for people of color, the lack of long COVID infrastructure within EHRs and other technology resources within healthcare systems, and the lack of long COVID clinics that were accessible to different folks. So thinking about this and understanding what people with long COVID wished that their care team members knew, the kind of resounding request was really having folks understand that this is awful. It's an awful condition. Some days are worse than others. People aren't being whiny, weak, or crazy. So people were being described as being drama queens and hypochondriacs. The condition is real, it's hell, and they need help. So having that acknowledgement of the impact of long COVID on quality of life was really the number one request. So understanding that disruptions to life related to long COVID occurred at the individual level, at a household level, and at work and school community levels. So the concept of gaslighting and how healthcare providers, healthcare systems, because of a lack of knowledge, would downplay symptoms, downplay severity, kind of give a, oh, you can shake it off, you can get better, you're making it up. So really wanting to have that acknowledgement was a core request of folks with long COVID. At the individual level, as I had mentioned, there's that deep-seated frustration that really on a dime, your levels of activity and engagement and energy shifted from how you were previously able to behave to how you were feeling now. Also understanding that, as I had mentioned, depression and anxiety will result from long COVID because of how someone has to manage it. It's not necessarily because of the condition itself. So having people take you seriously. So if you're saying you're in pain, taking it seriously. You don't want to just be told, like, take some Tylenol. You want people to actually investigate and help figure out what's wrong with you. Looking at the quality of life for a household. So understanding for many people, the ability to engage in regular household chores like cooking or doing laundry, that was off the table. So other family members are picking up the slack. So the level of independence, level of autonomy really shifts. And for folks who are living at home, that really impacts family and partner dynamics. For people who live independently or who live by themselves, it really impacts the need of level of care that is needed. For people who have particularly younger children, they really talked about the impact to their relationship. For someone who was hospitalized and basically told they were going to die, it was really traumatic for their children. So this individual talks about how her daughter, she talked about her daughter is now in counseling, but it's like, how am I going to leave you when I almost lost you? And her sons are going to remote college because they don't want to leave her. Also, for this other person on the other side of the screen, she said, my relationship with my daughter has changed as I can't deal with being around everyone, even them for more than an hour or so. So I isolate myself in my bedroom because they give me a headache. And when we were talking, she was telling me she has a 8-year-old daughter. And so just being able to be active and engaged with a daughter, with children, with grandchildren, with having that external stimulation, it's really too much. In terms of sort of quality of life, work and school, of the people that I spoke with, a quarter of respondents indicated that they left their job or dropped out of school because of long COVID. An interesting kind of subset of people were nurses who were frontline healthcare providers early in the pandemic, who contracted COVID-19 and are now experiencing long COVID. And they did not have the cognitive ability they felt to do their job, nor the stamina to be on their feet for a long time, to be working with patients. Other people talked about how some of the physical impacts of long COVID really hindered them in doing their jobs. One really heartbreaking one for me was a concert pianist who no longer was able to play the piano because they didn't have the concentration or the dexterity any longer. Thinking about care delivery, again, there's this gaslighting concept. So really listening to the patient, listening to the resident, understanding that long COVID is real, it's debilitating, it's scary. More than half of the people that I spoke with via interview and survey really focused on wanting validation of their experience of long COVID. So again, they were told they were hypochondriacs or drama queens, or that they were limiting themselves. So really wanting healthcare providers and healthcare teams to take responsibility to educate themselves about long COVID and how to work with people who have the condition, rather than just saying, well, your tests look normal, so you're fine, you're making it up. Because for many people, their labs look normal, their tests look normal, but they're still experiencing the condition. There was a really great deal of frustration that people reported about lack of integrated team-based approaches to care, particularly for folks who contracted COVID-19 early in the pandemic. We all remember it, everybody was kind of scrambling, it was scary. So if you were recovered from COVID-19, no longer testing positive, it's April, May 2020, you're still feeling sick, but you're not testing positive. So you're not able to get to the hospital, you're not able to get care. Nobody knows what's going on. And folks are saying it's not really getting better. So really wanting their doctors, their nurses, their specialists, social workers, if they are in a supported care situation, their team members at their residence, to kind of all be on the same page about what their health status is, what the impact is, and having the right hand know what the left hand is doing, essentially. And then understanding that long COVID can really intersect with and amplify trauma that people experience. So this is a quote from a woman with mixed Latina and Indigenous backgrounds and cultural practices. And she said, basically, the system isn't designed for me. I don't need another white man making me pay to run a bunch of tests that exhaust me and don't tell me anything. I've already explained what's wrong with me for 2 years, but they don't know about it and they don't want to admit it. The only time they care is when they want my blood or something, and I don't want to be a lab rat. I've put in enough time attempting to access care for long COVID. So come back when you have some answers I can use, and you can respect me as a person, not a problem. So long COVID, not so good. How can we help support people with long COVID? So particularly with respect to technology, there are some actions that can be taken now, and there are some things that you can do to help move things forward. So what you're seeing on screen was really designed for a primary care audience, but a lot of this is very applicable to residential care settings. So documenting long COVID as a problem using the ICD-10 code. So just having documentation about, just like you would indicate somebody has diabetes or that they have, that they're on blood thinners, you want to document that they have long COVID. You want to document the different symptoms related to long COVID as well. You can provide technology assistive devices. So these include wearable monitoring devices, Fitbits, Apple Watches. Even if a person isn't super mobile, being able to track and understand energy expenditure is really key to not pooping out too soon, too fast. Other folks, again, had talked about how they had light sensitivity. So providing blue light blockers in terms of glasses or screens was found to be very helpful, as well as light dimmers on lights. Having magnifiers, having text-to-speech tools, and then having different styluses or grips that were supportive for people who are having dexterity issues. Creating health communication plans that allowed proxy participation. So my guess is if you are dealing with residents who are older and have younger family members who are adults, bringing them in and having them be part of that kind of team-based approach to care and to making sure that the resident is doing well. So coming up with a way in a healthcare setting to have a proxy that the patient chooses be part of their approach to care and advocate on their behalf. Ensuring that communication options are fully accessible for folks who have auditory, visual, and fine motor skill challenges. Suggesting and supporting practice of early morning meditation or mindfulness activities. So of everyone I spoke with, of the 200 or so people I spoke with, the people who are managing their long COVID the best all seem to be doing either a form of prayer or meditation or mindfulness or breathing work early in the morning on a daily basis. And they felt that this was one of the cornerstones that helped them with managing their long COVID. It gave them something to look forward to. It helped with their cognition. So this was something that many of the people with long COVID were really recommending. So apps like the Calm app or different meditation apps were really recommended. In terms of moving things forward, if you're using an EHR, an electronic health record system, just supporting updates to it to make it more long COVID friendly, particularly with different communication options. If you're contacting care venues on behalf of a resident who has long COVID, again, asking about the different communication options. So can they do a video visit instead of coming in face-to-face? Can they do a phone visit? Things like that. Supporting the creation of accessible long COVID clinics, so video long COVID clinics as opposed to having to go into a healthcare setting. Establishing infrastructure that supports and educates family members and caregivers. So family members of those with long COVID, especially if they're not seeing that person on a day-to-day basis, may be shocked by the changes that the resident experiences. So being able to support and educate them in really understanding that and supporting the resident is really key. For healthcare providers, adopting and integrating remote monitoring programs for targeted health issues. So having, blood pressure checks on a regular basis and sharing those in. Just sort of working to set up remote ways to capture health data without having the patient to go in. And then capturing and documenting mental health and alternative medical practices in a structured way. So for your residents who are internet savvy, there are lots of discussion groups and lots of pockets online of people who share different alternative medical practices that they do that they believe support their long COVID management. Some of these include supplements, some of these include things like acupressure, acupuncture. If your patient is especially taking supplements, make sure that you know that just to look for drug interactions and making sure that you kind of have a good idea of what your patient or your resident is up to. So I did spend quite a bit of time digging into the literature to look at people in long-term and post-acute care settings with long COVID specifically. And there is a distinct lack of research that has been done in this area. I could actually only find 2 studies that really focus on COVID-19 survivors in long-term care facilities. and they were not great studies just from a research standpoint. So there has been sort of a call to action put out by the American Geriatric Society saying we need to look at this specific population with long COVID, but the research isn't quite there yet. In general, they have documented for people with long COVID in long-term care facilities that there are poor health-related outcomes related to malnutrition and weight loss and frailty compared to people who are not experiencing long COVID. And they haven't really looked at a ton of differences in health outcomes, especially long-term for people with long COVID versus acute COVID only. So meaning they had an initial COVID-19 infection and then they got better. So I wanted to really find out some practical advice and things I could share with you. So what I did was I turned back to the internet and I worked with people who have long COVID, as well as some networks of different healthcare providers, including geriatric specialists, as well as staff members who work in long-term care facilities, to just kind of get some ideas about some applied practical advice that you could take back in working with your residents. So this is what they suggested, or what they wanted you guys to be aware of. When it comes to activities for residents, keep them at 45 minutes or less. So anything over 45 minutes is really too much, too intensive, and limit things to one main activity a day, preferably early in the morning. So like I mentioned, sunsetting is a very common experience for people with long COVID. If you add age to that, you add other comorbid conditions to that, keep it to one activity, keep it to 45 minutes or less, try and get it earlier in the day. There was suggestion on managing symptoms rather than rehabbing patients. So for a majority of people with long COVID, traditional rehabilitation practices where you slowly amp up are not helpful. They can actually cause a severe setback for folks with long COVID. So symptom management and kind of maintenance is recommended over kind of the traditional rehab structure. Really looking at pacing and supporting people and how they manage their energy management. So I don't know if folks are familiar with spoon theory for chronic disease. If you are, you'll hear about it again. If you're not, something new. But spoon theory, or spoonies, is a concept that people with chronic disease have adopted from an essay that came out in the early 2000s. And the idea is basically that you have units of energy that the author called a spoon for the day. So I have 12 spoons worth of energy for a day. And I know I need to spend 1 spoon getting dressed in the morning, and I need to spend 1 spoon having breakfast, and I need to spend 2 spoons getting to work or getting to school. And then my, typical work day is going to cost me 6 spoons, and then getting home is another spoon's worth of energy. And, then getting ready for bed is another spoon's worth of energy. So the idea is that you have this set unit of energy for the day. And if you go over that, it doesn't reset you at baseline the next day. So if you have 10 spoons worth of energy for the day and you use up 12 spoons worth, then you start the next day at a deficit. You start the next day down 2 spoons worth of energy. And it takes a long time, and it can actually cost you energy to build back up to your baseline. So being able to manage your spoons, which is a comment that a lot of folks with long COVID will say, is really key to being able to kind of live life on the day-to-day over the long term. So the idea is not to burn out too fast, because it really can cause a setback over the long term. The other thing that folks who deal with older patients really wanted to highlight for y'all is that many long COVID symptoms mirror dementia. So if you are going to be examining a patient for dementia, attempting to treat a patient for dementia, especially using medication, be cognizant that the symptoms that they're displaying may be attributable to long COVID rather than dementia itself. And so treatment for dementia may be counterproductive for that resident. So there is no firm diagnostic test for long COVID. It's really detective work. It's really looking back and saying, when did these symptoms start, and tying it to a COVID infection, a COVID-19 infection. But just, it's a problem. I don't have an answer for it, but just something to be very aware of, that your long COVID symptoms may, particularly brain fog, cognitive issues, may mirror dementia expression in the residents that you're working with. So taking all of these, how do we help people? How do we work with people? Like I'm an academic, I'm a researcher, we love a model. So this is a model that talks about ways of supporting people with long COVID. There are technology sourced methods. So devices, technology assistive devices, different wearables, integrating different alternative medicine, external mental health support, and meditation into an electronic health record, having a formal method for a proxy, a friend or family member to participate in care, as well as providing them education and support about long COVID, coming up with alternatives for face-to-face visits. So video visits, phone visits. A very common request was, instead of sending an email to a healthcare provider, being able to send a secure video message. This was actually how many people with long COVID talked about communicating. So instead of text messaging, they would send family members video messages. Everything from please pick this up at the grocery store to here's how I'm doing today, because it was just easier to navigate on different devices. And then system level, coming up with long COVID infrastructure and documentation in the patient's chart and their medical record, and highlighting that in their problem list. And then with respect to communication, wanting to make sure that it was appropriate for the resident or the patient. So understanding that there are different cultural communication norms, that communication is going to be based around need, and it may be audio only, visual only, both, synchronous, happening in real time, asynchronous, meaning that there's a delay, and really being adaptive to the needs of the person with long COVID. So taking this, and we want to do it for our folks with long COVID, but being able to deliver this information and support patients in a trauma-informed way. So again, folks really just want that acknowledgement of, I have long COVID, this is the experience that I have. We want to recognize it, acknowledge it. We want to recognize the traumatic effects of long COVID on health and quality of life. Understand that the experience of long COVID can amplify or compound prior health-related traumas, particularly for people of color, people who are kind of not your white cisgendered men. Acknowledging different long COVID knowledge gaps in healthcare staff and working to close them, and then sort of centralizing the patient in an integrated team-based approach to providing care. So we take that model and we overlay our trauma-informed long COVID care and interaction filter to it and tie it to that earlier model. So, and this is another model that I'll share with Adrienne to email out to everyone, but basically looking at the individual layer, the family and community layer, and then at healthcare systems, what different variables are that influence care access, and then what can be done to support people with long COVID, and understanding that there's not an expectation we're going to solve this overnight, but there are some clearly defined steps or behaviors that you can do to better support those residents who are experiencing long COVID. And just to kind of close this out, I want us to have some discussion, but I did want to share with you an art piece that I really think just sort of drives home the need for trauma-informed long COVID support. This is an art piece that a teenager named Rosie made, and she is part of a group called Long COVID Kids. And these are all comments that she and other teenagers have heard about long COVID. So these are from other healthcare providers, these are from other individuals. Things like, you look healthy, it could be a lot worse, just give it time. You could just be tired, all teens are. COVID made me very lazy too. Being positive will make you feel better. You should try exercising more. You have to be more positive. You must be better. I see you out with your friends on social media. You would feel better if you didn't spend all day in bed. Have you tried mindfulness? It's okay, I'm tired too. It must be your subconscious. So I really, with this, want you to, if you take anything away from this, really understand the deep impact that long COVID can have on individuals, and kind of the novelty and the fear that surrounds it, and the need for trauma-informed support that residents, that folks with long COVID need. So with that, I'm going to stop sharing my screen so I can see all of your faces. And I'll share this real quick. So if you want to talk, happy to talk. This is my email here at Comagine. I'm also fairly active on Twitter, although it's a little bit of a interesting landscape now. But I am happy to chat with you if you do want to kind of dive into this any further. And I also just really want to thank the people with long COVID who participated and trusted me with their stories. It's very humbling to have had the trust of the folks who've worked with me on this. And as I said, much of this is part of my dissertation data. So not only was it approved by the Northeastern IRB, but as soon as I defend it, which will hopefully be in the next couple of months, I am happy to share additional stuff, but anything that I've shared on screen is fine for distribution if you're interested in further sharing this. So let's see your faces and have a little discussion if folks have any questions or comments that they want to share.
Please feel free to unmute or put any questions or comments that you have in chat. I did put Laura's email address in our chat box. So if you have any questions about anything she shared with us today, or resources or further information, please feel free to reach out to her or myself and I can get you connected. It looks like Donna has asked, says, great presentation, thank you. And then, do you know if there are numbers of those suffering from long COVID?
Yes, yeah, there are. So basically, there are undercounts, but over 10 million people in the United States. And you basically can assume 1 out of 10 people who don't die from COVID-19 will have long COVID symptoms. So it's a very large population. Sometimes people don't recognize it. Other times they attribute it to other conditions. But kind of the common rule of thumb is 1 in 10 people who survive COVID-19 will have long COVID. And then it gets, and the odds go up if you have other comorbid conditions.
Thank you. What other questions do we have for Laura? Or even just thoughts? Is there anything that maybe you thought was surprising, or that was, maybe something you hadn't heard before? I know we do have some social work folks on our call today. I'm curious if any of you have any experience working with the Utah Long COVID Clinic, and if you have any thoughts or experiences to share from that. We do have a rather newly established long COVID clinic here in the Salt Lake Valley, at least, and I know they've been very active. And then I saw you come off mute, Donna. You're welcome to share.
Oh, I couldn't get I was going to do my video too, but it's not coming up, but that's fine. But I'm just amazed at the numbers myself. I didn't realize it was that large. I'm an infection preventionist at Furcrest, which we take care of people with intellectual disabilities.
Mm.
And it makes me wonder, because I know we had early on in the pandemic, we had some staff have to quit work because of long COVID and some cardiac issues. And it makes me just really worry about how they're doing now.
Yeah. Yeah. I mean, it's a really horrible condition. I've heard it described as almost being an inflammation. So I'm going to preface this with, I am not a clinician. So I'm a researcher, but not a clinician. But I've heard it described as almost an inflammation of blood vessels. So any part of your body that has blood going through it could potentially be impacted by long COVID. Are folks able to apply for any benefits from the government? Not really. It's just starting to be recognized as a disability condition. And I say that, like, I think in the last 2 or 3 months. It's not something that folks can use if filing for unemployment. And sort of worldwide, the only country that I've really seen start to take kind of definitive action about providing benefits for patients with long COVID has been in the Netherlands, in terms of like supplying a stipend, basically for folks who are no longer able to work.
Those good old Netherlands.
Well, and that was like as of 3 days ago.
Yeah.
So it's very slow moving. But this really, at least in my mind, it's sort of the sleeping giant, because we just have this potentially enormous population that could be impacted or maybe impacted with long COVID. And, we're finally coming to the tail end of the pandemic, knock wood. But there's still this, potential wave of folks who may be impacted, and it's a chronic condition at this point. So people have been experiencing this for 2-3 years without much relief. So especially for folks who are who provide residential care, this is definitely something to be mindful of and keep an eye out for.
Yeah, it certainly makes me think about that statement you made about regardless of if this body of work really directly relates to your medical practice or your actual specialty, knowing that what's going on and staying up on the most important, latest information still really benefits everyone, regardless of if you're, in infection prevention or working in other specific areas. It's really important that we keep this information at the forefront and really connect the dots with the whole care team and everyone involved.
Absolutely.
We do still have a couple, maybe 1 minute or so left. If you have any questions that come up after this session, please feel free to send me an email and I can work with Laura to get your questions answered or send you more resources or information. We are just really, really grateful to have Laura as our healthcare evaluation manager at Comagine Health. She brings a lot of amazing expertise here to the table, and we are really pleased that you are able to access her with any of your questions or issues that you might want to have addressed. So please feel free to reach out. And then if there are not any further questions at this moment, we can go ahead and wrap up. And then as you are exiting the Zoom, there will be a evaluation poll that pops up. That'll be where you can put in your information in order to receive your continuing education credit for social work today. And if you have any questions about any of this at all, please feel free to send me an email, and we will share the resources that Laura mentioned in her presentation back out to you via email as well. So thank you very much, Laura. Really much appreciate it. Excellent presentation. And everyone have a great day.
Thank you.